سبيكر هيكون دكتور جهاد صالح هنتكلم عن الMRI imaging ايه concepts
Assalamu alaikum. It's my pleasure to be today here with you. Talk about the MRI imaging for endometrial carcinoma. Endometrial cancer is the second most common gynecologic cancer worldwide. The MRI provides critical diagnostic information in the pre-treatment setting. The American College of Radiology and European Society for Genital Radiology recommend MRI for pre-treatment assessment of endometrial cancer. Although endometrial carcinoma is a surgical stage disease using the FIGO classification system, MRI can provide very critical information to choose the proper medical treatment. Till now, we use the FIGO 2009 on our records for preliminary staging of the endometrial cancer. Recently, the FIGO has been updated in 2023. For each stages, for all stages, we showed the record, the histological type, the tumor grade, lymphovascular space invasion. The histopathological findings are the central feature in the updated 2023 FIGO classification system. But the basic rule of the imaging modality and the pre-operative evaluation point in the MRI are not significantly changed. Till now, we didn't use this classification system in our report. Still need prospective study for its validation. The endometrial carcinoma is classified into two histopathological subtypes. Type 1 occur with hyperestrogenic state, usually diagnosed in early stage, include grade 1 and 2 endometrioid adenocarcinoma. It has good prognosis, while type 2 is more aggressive, usually diagnosed at advanced stage, could be presented with peritoneal carcinomatosis, such as ovarian cancers. It includes grade 3 endometrioid adenocarcinoma, serous, clear cell, undifferentiated carcinosarcoma, and the other rare types. It has poor prognosis. This figure shows the initiation and the progression process of the type 1 and type 2 endometrial carcinoma. Type 1 arises from endometrial hyperplasia associated with P10 mutation, while the TP53 mutation occurs late. The more aggressive type 2 arises from serous endometrial intraepithelial carcinoma, start with TP53 mutation. The traditional classification of endometrial carcinoma into type 1 and type 2 doesn't give significant information about the biological behavior and the prognosis of the endometrial carcinoma. So the integrated genomic classification classifies the endometrial carcinoma into 4 types, where the type P53 has the worst prognosis. The NCCN guidelines recommend the pelvic MRI for initial workup in endometrial carcinoma. For proper MRI protocol, we should have proper clinical data about any previous hormonal medication or surgical procedure. Patient asked to fast and avoid before examination. Antiperistaltic agent may be injected intramuscular or intravenous to decrease the motion-related artifact. MRI protocol include large field of view, axial T1 and T2 weighted image for proper assessment of the para-aortic nodal status, secondary sign of extraterrine extension such as hydronephrosis. A small field of view is the key player and cornerstone in the MRI protocol, include axial oblique and sagittal T2 weighted image. Also, MRI protocol include diffusion and contrast enhanced MRI. The axial oblique T2 weighted image is the mainstay for diagnosis of the myometrial infiltration, which is one of the most important prognostic factors. For uterine corpus, we use in the axial oblique T2 weighted image are planed perpendicular to the endometrial cavity, while for the uterine cervix, the axial oblique T2 weighted image are planed perpendicular to the endocervical canal. Here, the yellow line indicates the coronal plane, while the red line indicates the axial oblique plane. A high resolution axial T2 weighted image should be obtained with a small field of view, a slice thickness less than 4 millimeter. The normal zone anatomy is well delineated in sagittal and axial oblique T2 weighted image. We have the hyperintense endometrial cavity surrounded by T2 hypointense junctional zone, which is continuous caudally with the inner fibrous cervical stroma, surrounded by intermediate signal intensity myometrium, which is continuous caudally with the outer interstitial cervical stroma. Diffusion weighted image is a functional, fast, non-contrast MRI sequence. It adds very good contrast tissue based on the Brownian motion of the water molecules. It really shows what's inside out. It should be obtained at least with 2 p-value, high and low. It can be obtained at 2 plane, axial, oblique, and sagittal, with the same orientation as the T2 weighted image, or at least 1 plane, axial, oblique. Contrast enhanced MRI endometrial carcinoma setting can be obtained as a single phase, excision time at 2 minutes, 30 seconds, as this provides the best contrast between the endometrial lesion and surrounding myometrium. Or we can done contrast enhanced MRI as multi-phase, early phase for assessment of the subendometrial enhancement, equilibrium phase for detection of the depth of myometrial invasion, while the delayed phase helpful for detection of the cervical stromal invasion. MRI appearance of the endometrial carcinoma. We have here axial oblique T2 weighted image, endometrial cavity distended with intermediate signal intensity mass, which show restricted diffusion in the form of hyperintensity and high p-value and corresponding hypointensity in ADC map, and hypoenhancement and contrast enhanced T1 weighted image. Myometrial invasion, as we said, is one of the most important prognostic factors in endometrial carcinoma. We should confirm presence of myometrial invasion, differentiate between superficial and deep myometrial invasion, as the deep one has higher risk for lymphovascular space invasion and nodal metastasis. Axial oblique T2 weighted image revealed endometrial carcinoma of intermediate signal intensity, surrounded by intact, uninterrupted hypointense junctional zone, with the intact, smooth, uninterrupted band of subendometrial enhancement in early phase. These signs exclude the myometrial invasion. Common pitfall when large endometrial mass, which cause compression of the surrounding myometrium, giving false impression of myometrial invasion. However, the presence of intact hypointense junctional zone and intact early subendometrial enhancement exclude the myometrial invasion. Myometrial invasion diagnosed by interruption of the normal T2 hypointense junctional zone and interrupted enhancement at endometrial myometrium interface. For accurate assessment of the myometrial invasion depth, we draw a line along the inner margin of endometrial myometrial interface at axial oblique weighted image. Then we draw 2 perpendicular lines. One measure the whole thickness of the myometrium, and the other one measure the maximum extension of the tumor into the myometrium. The ratio between these 2 perpendicular lines represents the depth of myometrial invasion. The upper row shows superficial myometrial invasion, while the lower row shows deep myometrial invasion. Another common pitfall in assessment of the depth of myometrial invasion is the poor tumor to myometrium differentiation, owing to the isointensity of the endometrial mass to the surrounding myometrium. Diffusion weighted image provide better delineation of the tumor margin and assessment of the depth of myometrial invasion. Also, coexisting endometrial carcinoma with multiple myoma, which may distort the zonal anatomy of the uterus. However, the diffusion weighted image endometrial carcinoma show restricted diffusion, unlike the typical leiomyoma, which show free diffusion, thus help delineation of the tumor margin and accurate assessment of the depth of myometrial invasion. Also, coexisting adenomyosis may cause pseudo-widening of the junctional zone, giving false impression of myometrial invasion. Even in T2 weighted image and post-contrast enhanced image, both the endometrial carcinoma and adenomyosis show hypoenhancement. However, the diffusion weighted image here can delineate the accurate margin of the endometrial carcinoma and help assessing the depth of myometrial invasion. Another important prognostic factor is the cervical stromal invasion, diagnosed by interruption of the normal T2 hypointense cervical stroma. Cervical stromal invasion can occur without involvement of the endocervical mucosa, as the endometrial carcinoma can extend directly from the adjacent myometrium to the cervical stroma. Extension of the endometrial carcinoma into the endocervical canal, or even widening the endocervical gland with preserved intact T2 hypointense cervical stroma, doesn't indicate cervical stromal invasion. This image shows the key signal intensity characteristic of endometrial carcinoma. We have here endometrial carcinoma at lower uterine segment, intermediate T2 signal intensity, restricted diffusion pattern. Early phase dynamic contrast enhanced MRI shows subendometrial enhancement with focal interruption here at the white arrow. At equilibrium phase, you can see the best contrast between the endometrial carcinoma and surrounding myometrium, while the delayed phase confirms the presence of cervical stromal invasion. Differentiation of the ovarian metastasis from synchronous primary ovarian malignancy can be an ongoing challenge in the imaging. Some features can help to differentiate between both. Ovarian metastasis usually coexist with endometrial carcinoma with deep myometrial invasion, bilateral ovarian involvement, morphological similarity between the ovarian and uterine masses, while the synchronous primary ovarian malignancy associated with early endometrial carcinoma with no or superficial myometrial invasion makes it solid and cystic complex ovarian mass, previous history of endometriosis. You can see here a case of coexisting endometrial carcinoma and the multiple intramural leiomyomas. Again, the diffusion-weighted image helps the better delineation of the tumor margin and assessment of the depth of myometrial invasion. Axial oblique T2-weighted image, contrast-enhanced MRI, and diffusion-weighted image reveal extension of the tumor into both adnexal region, coping with ovarian metastasis. Another case of endometrial carcinoma with large, complex, solid, and cystic ovarian mass. No deep myometrial invasion or extraserosal extension, coping with synchronous primary ovarian endometrial carcinoma. The serosal involvement can be diagnosed by interruption of normal T2 hypointense uterine serosa and the interruption of the normal REM enhancement at the outer uterus. The nodal involvement pattern is affected by the location of the endometrial carcinoma. Endometrial carcinoma at fundus or upper uterine segment usually drain into common iliac or para-aortic lymph node, while endometrial carcinoma at mid or lower uterine segment drain into paracervical obturator, internal external iliac lymph node. Assessment of lymph node MRI rely on size and morphologic criteria. A short axis diameter more than 5 mm in pelvic lymph node or more than 8 mm in pelvic lymph node or more than 10 mm in abdominal lymph node are suspicious. Regardless of size, when the lymph node is necrotic, heterogeneous signal, irregular margin, or rounded, is considered suspicious lymph node. One of the common limitations of MRI in nodal assessment is that micrometastasis may present a normal size lymph node, so correlation with PET-CT is helpful in such a situation. Bladder and rectal involvement diagnosed by loss of the fat plane between the uterus, bladder, and rectum with interruption of the T2 hypointense muscle layer in bladder and rectal wall. You can see here a sagittal T2-weighted image, large endometrial mass with extensive breakdown and necrosis involving the posterior wall of the urinary bladder. Contrast-enhanced sagittal T1-weighted image confirm the extension into posterior bladder wall, coping with large uterine vascular fistula. A common pitfall at bladder involvement is bullous edema sign. Bullous edema sign, as you can see here, is hyperintense thickening of the mucosa of urinary bladder. It's not direct sure sign of bladder invasion, must be assessed carefully for any associated tumor nodule, such as seen here in this case of true bladder invasion. Sometimes fertility-sparing treatment of endometrial carcinoma is an alternative option for young women with disease limited to the endometrium. This conservative treatment consists of oral progestin via intrauterine device. The criteria for considering fertility-sparing treatment in endometrial carcinoma are pathological, radiological, and clinical. For MRI, disease must be limited to the endometrium. We must confirm absence of myometrial invasion, absence of suspicious or metastatic disease. All these criteria must be met to proceed for conservative treatment. Addition of dynamic contrast enhanced MRI is helpful as it confirms the absence of myometrial invasion by intact subendometrial enhancement at the early phase. This example of case underwent fertility-sparing treatment. Baseline MRI shows small intermediate signal intensity mass with the intact junctional zone. At follow-up MRI, it showed progression of the mass. The treatment was unsuccessful and patient underwent a hysterectomy. For restructured MRI report, we have many available templates online. The European Society of Urogenital Diagnosis supposed this is mnemonic clinical and MRI critical team to summarize the key element in the structured report. Clinical for clinical data, MRI, myometrial invasion, critical for cervical stromal invasion, team for tumor extension into serosal, vaginal, adnexal, bladder, rectum, and M for metastatic lymph node or distant mets. As we said, we have many available templates online for the structured report of endometrial carcinoma. Finally, the promising field of artificial intelligence and deep learning is one of the most outstanding development in medical imaging and radiology. The application of deep learning reconstruction technique at the benefit of less acquisition time and higher quality. Image features from different sequences are processed separately and then integrated together with clinical, histologic, genomic information toward the enhanced discovery of the non-invasive biomarker for prognosis or even treatment response. It's still area of research, and further larger radiomic multi-center cohort studies are required to validate the proposed models. To sum up, MRI is recommended for initial staging of endometrial cancer, diffusion-weighted image and dynamic contrast enhanced MRI, improved tumor delineation and staging accuracy. Thank you.